And next, complex chip PCI from Dr. Refal, Shoukath Ali.
Thank you for the organizers for me to show my case of a left main bifurcation PCI under OCT guidance assisted by intravascular lithotripsy with intra-aortic balloon pump support, which is done within the last 6 to 7 months. So our gentleman is a 73-year-old gentleman with a history of diabetes for 20 years, hypertension for 15 years, presented with recent onset effort dyspnea. He underwent an ECG in his local hospital, which showed some evidence of left ventricular hypertrophy. An echocardiogram showed normal LV function with no regional valve motion abnormalities, with a calcific aortic valve with a mild aortic stenosis with a mean pressure gradient of around 20 millimeter mercury. He underwent a treadmill test, which is positive for inducible ischemia at stage 2, and therefore they did a coronary angiogram in the local hospital. So this is the angiogram, which you can see on the screen. This is the caudal view. It's showing that the left main, distal left main disease involving the ostium of the LAD and the ostium of the circumflex artery. You can see some calcification noted in the left main and the ostium of the LAD. On the cranial view, you can see the mid-LAD has got a very tight stenosis. And on the spider view, which is the LAO caudal view, you can see the bifurcation angle very clearly. It is around 70 to 90 degrees. The right coronary artery was a small, non-dominant, and the diffuse disease, they could not intubate it, and therefore they did a non-selective injection. So on syntax score 1, his syntax score 1 is around 26, and a syntax score 2 showed a 4-year mortality rate of around 8.6% for CABG and PCI. You can also see there is a high obtuse marginal branch, which is a good size vessel, has also got a severe stenosis of the ostium. Considering this, we had a discussion with him about the options of CABG and PCI, and considering his age, he opted for PCI, and therefore we decided to go for PCI. As we all know about the definition 2 study, that when we have a bifurcation PCI, I will normally follow this criteria, and in this particular case, it's a left main distal bifurcation. The diameter stenosis is more than 70% angiographically, and the side branch lesion length is around more than 10 millimeters, suggesting this patient should have a complex PCI strategy with 2 minor criteria, because it's got moderate calcification and a longer main vessel disease of more than 25 millimeters. So when you have a complex PCI, it's better to go for a upfront 2-strand strategy. And as you know, in definition 2, most of them used a DK crush technique. Around 70 to 80% of the patients had DK crush technique. And we know that the outcome of DK crush technique is much more better compared to other 2-strand strategies when it comes to bifurcation PCI. So considering he has got a left dominant system, I started with the intra-aortic balloon pump to the left femoral axis, and to the right femoral axis with the Simon French guiding catheter. Angioplasty was started. So the plan was to wire all 3 arteries, the LAD, the circumflex, and the high obtuse marginal artery. All 3 of them were wired, and a 2.5 millimeter by 15 millimeter balloon was used to predilate all the lesions in the circumflex, OM, and the LAD. On the LAD, you can see there is a wasting of the middle of the mid-LAD segment with a 2.5 balloon, and therefore we decided to do an OCT run. This is the OCT pullback from circumflex to the left main, and this is the OCT pullback from LAD to the left main. You can see the OCT. The left-hand panel is the circumflex pullback, and the right-hand panel is the LAD pullback. For the time reasons, if I just go, there is at least 260-degree arc of calcium in the circumflex artery, and around 360-degree calcium in the LAD, mid-LAD, and the proximal LAD, with a depth of calcium more than 0.5 millimeter. Therefore, this gentleman would need an upfront plaque modification strategy, and considering his large vessel, I directly decided to go for IVL therapy. So I used a 3 by 12 millimeter IVL at the mid-LAD, 20 pulses given, and then a proximal and the left main LAD, another 20 pulses is given. And this is the angiogram post-IVL. And this is the OCT run post-IVL, which showed calcium cracks in the post-IVL and at least more than 180 degrees, suggesting that there is good modification of the calcific plaque burden. Follow that, I put a 3.5 into 28 millimeter DES in the circumflex artery with the guidezilla support, so the 3.5 to 28 DES. And while I'm doing the DES, I had a 3 balloon ready in the LAD, and I pulled back that balloon to do a sequential crush with 3 first and then a 4 balloons to crush the circumflex stent. Followed by, we did a wire recrossing, which is done with the proximal stent spread, which is a stent boost images showing my wire crossing at the proximal stent spread, followed by the kissing balloon inflation, the first KBI, and then a mid LAD 3 by 28 millimeter test and a 4 by 33 stent from the left main into the LAD, overlapping the lady stent. And a 4 by 12 millimeter NC pod balloon was used to the proximal LAD, and then the second rewiring was done into the circumflex, and the second kissing balloon inflation was performed with a 3 by 8 into the circumflex and a 3.58 to the LAD at around 14 atmospheres. And then I used a 4.5 into 8 millimeter balloon to report it, and then followed by, we did a OCT run. This is the OCT run, which is showing the three-dimensional view of the bifurcation view, telling me that the ostium of the circumflex is strut-free, except there is a one small strut coming at, but otherwise the ostium of the circumflex looks clean and open up for at that segment. On the left main, I got a minimal stent area of 14.41, and the two-dimensional bifurcation view, you can see the ostial circumflex without any stent struts. But nevertheless, there is a malapposition at the proximal part of the left main stent. Even though it's not that obvious, criteria of 400 microns is not reached, I decided to use a 5 millimeter balloon to post-dilate further to make sure that the malapposition get deployed. This is deployed at around 14 atmospheres. And this is the final result after this complex bifurcation PCI. As you can see, all branches are well preserved. The obtuse marginal was also just ballooned it. I didn't decide to put any stent in the obtuse marginal artery. And you can see the left-hand panel is the pre-PCI and the right-hand panel is the post-PCI angiographic images, suggesting we had a good result. So in conclusion, ladies and gentlemen, this is a severe calcification in the left main is considered to be one of the main challenges in left main bifurcation PCI. Intracoronary imaging to assess the extent of the calcification to decide the strategy is a key tool in left main PCI. OCT can be used in non-ostial left main, as we all do, to accurately assess the calcific burden. Intravascular lithotripsy is particularly useful in large vessels like these kind of patients where we have a large left main, and this is considered to be superior in this particular situations than other plaque modification strategies. As we all know, DK crush is a challenging bifurcation technique, but has been shown better long-term results compared to other techniques when performed by experienced operators. IABP as a support device in stable patients with left main PCI is still being used, particularly in patients who have impaired function. But in our patient, the LV was normal, but he had a left dominant system, and therefore I decided to put preemptively. Thank you for listening, and I hope we can have a discussion on that.
Well, thank you. So you are there live, right?
Yes, thank you. Yeah.
Thank you. Yes. Good. So first of all, congratulations. Nicely worked up case and planned strategy and executed, I would say. Everything else together. So good learning points, especially you used IVL for that calcified and you got fracture plates. But suppose if this patient would not have been would not have afforded an IVL, would there be any strategy, or you would have persisted of going to surgery?
No, I think I would. I mean, the problem is not about the surgery. The patient was completely scared of surgery. See, the option he gave was either you have PCI or nothing. So it's like he's categorically declined CABG. So that is where it's not like about the choice for the patient. We gave the choice, but he was in the impression that we very clearly, I don't want CABG, but I would rather go for PCI. But you're absolutely right. If it's IVL is not available, I would have used larger balloons like OPN or cutting balloons around 3.5 millimeter balloons to try and get some good plaque modification. We don't know exactly would have helped or not, but that could be the options I would have had in terms of cost effectiveness.
Yeah, right. So, and did you notice any calcified nodules anywhere?
No, not at all. It's a calcium plate.
It was a calcium plate superficial. Yeah. And at one point, it looked quite tight. Maybe the lumen there was not more than 1.75 or 1.5, I thought, at that place.
Correct. The LAD, the proximal and the
Yeah,
mid-LAD.
right. So in case your cutting or scoring balloons would not have gone, maybe you could have used Shoukath, prepared that, and then went ahead with the case. So I mean, I think it was nicely executed, and more important is, in case those people are doing DK crush without imaging, then you should liberally use 10 boost, which you were showing. Liberally use 10 boost, especially when you are trying to cross with the wire and you want to be sure your proximal mid wire crossing. Then you should use stent boost, as you were trying to show. I would have gone one step ahead. What I do is, because sometimes it is misleading also, the way I go with one more wire.
Okay.
And try to go into some other cell strut and see where it goes. If it goes easily into the distal to your proximal, then you know that you are proximal mid at least.
No, I agree. Totally agree. That's good.
Yeah.
Good
I mean, it will cost you one wire more, but at least you are saving imaging. I mean, the cost of imaging, just for the sake of that. So that's, of course, when you are using imaging OCT, then you can confirm on the imaging run also where you are, in which strut you are on the 3D also, as well as on the longitudinal. And we all follow the MLD max use of OCT beside that. So any follow-up of this case?
And no, he's no clinical. It's only clinical follow-up, no angiographic follow-up. He's doing extremely well. Clinically, it's now nearly 7 months since I did it. It's actually done as a live case for a Abbott meeting. So it was done on live in October or November. It's now 7-8 months. But I haven't done any angiogram for him. But clinically, he's absolutely extremely fine.
Good,
he's a 74-year-old gentleman. So
74, yeah. Right. So excellent. I think good luck to you and the patient. So thank you very much. We go.